Education activity. Myasthenia gravis is an autoimmune disorder affecting the neuromuscular junction. It manifests as a generalized muscle weakness which can involve the respiratory muscles and can lead to a myasthenic crisis, which is a medical emergency. This activity reviews the evaluation and management of myasthenia gravis, as well as the role of the interprofessional team in managing patients with this condition. Objectives. Identify the etiology and epidemiology of myasthenia gravis. Summarize the general history, physical exam findings, and evaluation of patients with myasthenia gravis. Outline the treatment and management options available for myasthenia gravis. Review interprofessional team strategies for improving care coordination in the management of myasthenia gravis to improve outcomes. Introduction. Myasthenia gravis, MG, is the most common disorder affecting the neuromuscular junction, NMJ, of the skeletal muscles. The classic presentation is a fluctuating weakness that is more prominent in the afternoon. It usually involves muscles of the eyes, throat, and extremities. The reduced transmission of electrical impulses across the neuromuscular junction due to the formation of autoantibodies against the specific postsynaptic membrane proteins consequently causes muscle weakness. A wide variety of conditions can precipitate MG, such as infections, immunization, surgeries, and drugs. Myasthenia gravis causes a significant number of complications. These include myasthenic crisis, an acute respiratory paralysis that requires intensive care, as well as adverse events due to long-term medication treatment like opportunistic infections and lymphoproliferative malignancies. A complete understanding of the pathophysiologic mechanisms, clinical manifestations, treatment strategies, and complications of myasthenia gravis is necessary for better patient care and outcomes. Etiology. Myasthenia gravis, similar to other autoimmune disorders, occurs in genetically susceptible individuals. Precipitating factors include conditions like infections, immunization, surgeries, and drugs. The commonly implicated proteins in the NMJ against which autoantibodies are produced include the nicotinic acetylcholine receptors, NACRs, muscle-specific kinase, MuSK, and lipoprotein-related protein 4, LPR4. Agrin LRP4 MuSK protein complex is essential for the formation and maintenance of NMJ, including the distribution and clustering of the AChR. 1. Approximately 10% of patients with MG have a thymoma, and it is implicated in the production of autoantibodies. 2. Myasthenia gravis classification. Depending on the type of clinical features and the type of antibodies involved, MG can be classified into various subgroups. Each group responds differently to treatment and hence carries a prognostic value. 3. Early onset MG. Age at onset less than 50 years with thymic hyperplasia. Late onset MG. Age at onset greater than 50 years with thymic atrophy. Thymoma-associated MG. MG with anti-MuSK antibodies. Ocular MG. Symptoms only from periocular muscles. MG with no detectable AChR and MuSK antibodies. Epidemiology. Myasthenia gravis has a prevalence of 20 per 100,000 population in the U.S. It exhibits a female predominance in those less than 40 years of age and a male predominance in those greater than 50 years of age. Childhood MG is quite uncommon in the Western populations but is prevalent in Asian countries, with the involvement of around 50% of patients aged less than 15 years. They usually present with symptoms of extraocular muscle weakness. 4, 5. Pathophysiology. The pathophysiologic mechanisms in MG are dependent on the type of antibodies present. In NAChR-MG, the antibodies are of the IG1 and IG3 subtype. They bind to the NACH receptor present in the postsynaptic membrane of the skeletal muscles and activate the complement system, leading to the formation of the membrane attack complex, MAC. MAC brings about the final degradation of the receptors. They may also act by functionally blocking the binding of ACH to its receptor or by enhancing the endocytosis of the antibody-bound NACH receptor. In MuSK-MG and LPR4-MG, the antibodies are of the IG4 subtype and do not have the complement activating property. They bind to the Agrin LRP4 MuSK protein complex in the NMJ, whose primary function is the maintenance of the NMJ, including the NACH receptor distribution and clustering. The inhibition of the complex leads to a reduced number of NACH receptors, 6, 7, The ACH released at the nerve terminal, in turn, is unable to generate the postsynaptic potential required to generate an action potential in muscle due to a reduced number of NACH receptors, leading to the symptoms of muscle weakness. The weakness is more pronounced with the repeated use of a muscle group, since it causes depletion of the ACH store in the NMJ. Histopathology. The histopathological findings in MG differ by the type of antibodies present. Muscle. In NACH-RMG, the muscles show significant atrophic changes, whereas, in MuSK-MG, there are minimal muscle atrophic changes and significant mitochondrial abnormalities, giant, swollen, and degenerative features. The differences suggest different pathophysiologic mechanisms of the two subtypes of MG. Neurogenic atrophy seems to be prominent in NAC-RMG, whereas mitochondrial abnormalities in MuSK-MG. 8. Thymus. In NACH-RMG, thymus shows epithelial hyperplasia and extraparenchymal involvement with T-cell areas and germinal centers, GCs. In MuSK-MG, the thymus shows age-related changes, and hyperplastic changes are very uncommon. In seronegative MG, infiltrates can be seen in half of the patients. 9. These findings of thymic epithelial hyperplasia and T-cell infiltrate suggest thymus is involved in the production of autoantibodies against the muscle proteins. History and physical. The distinguishing clinical feature of MG is the fluctuating muscle weakness that varies in severity, worsens with physical activity, and improves with rest. It can be precipitated by a wide variety of factors like infections, surgery, immunization, heat, emotional stress, pregnancy, drugs, commonly aminoglycosides, fluoroquinolones, beta blockers, neuromuscular blocking agents, and worsening of chronic medical illnesses. In history taking, patients should be asked about the timing of the symptoms, at what time of the day do the symptoms usually occurs, as well as improvement with rest. Inquire about subtle signs like coughing after swallowing, increased time to finish eating, hoarseness of the voice, easy fatigability in the climbing up stairs, and slow and frequent errors in writing or typing. These symptoms are most prominent at the end of the day or work shift. The most common symptoms include the following. Extraocular muscle weakness. Around 85% of patients will have this on the initial presentation. Common patient complaints include diplopia, ptosis, or both. These symptoms can progress and cause generalized MG involving the bulbar, axial, and limb muscles in 50% of patients in 2 years. 10. Bulbar muscle weakness. This can be the initial presentation in 15% of patients and causes symptoms like difficulty chewing or frequent choking, dysphagia, hoarseness, and dysarthria. 10. The involvement of facial muscles causes an expressionless face, and neck muscle involvement causes a dropped head syndrome. Limb weakness. This usually involves the proximal muscles more than distal muscles, with the upper limbs more affected than the lower limbs. Myasthenia crisis. It is due to the involvement of intercostal muscles and diaphragm and is a medical emergency. There are no autonomic symptoms like palpitations, bowel, or bladder disturbances that occur in MG, as it only involves the nicotinic cholinergic receptors. The physical examination may reveal normal muscle power because of the fluctuating disease pattern. In such cases, repeated or sustained muscle contractions can demonstrate weakness. Improvement is seen after a period of rest or application of ice pack test, to the muscle group involved. The pupils, deep tendon reflexes, and sensory examinations are normal. MuSK-MG has clinical features that are quite different from NACH-RMG. It is more common in females, relatively spares extraocular muscles, and commonly involves bulbar, facial, and neck muscles. Myasthenic crisis is also frequent in the MuSK-MG. 11. Clinical classification. The Myasthenia Gravis Foundation of America, MGFA, clinical classification divides MG into 5 main classes based on the clinical features and the disease severity. Each class carries different prognoses or responses to therapy. 3. Class 1 involves any ocular muscle weakness, including weakness of eye closure. All other muscle groups are normal. Class 2 involves mild weakness of muscles other than ocular muscles. Ocular muscle weakness of any severity may be present. Class IA involves predominant weakness of the limb, axial muscles, or both. It may also involve the oropharyngeal muscles to a lesser extent. Class IB involves mostly oropharyngeal, respiratory muscles, or both. It can have the involvement of limb, axial muscles, or both to a lesser extent. Class 3 involves muscles other than ocular muscles moderately. Ocular muscle weakness of any severity can be present. Class IA involves the limb, axial muscles, or both predominantly. Oropharyngeal muscles can be involved to a lesser degree. Class EB involves oropharyngeal, respiratory muscles, or both predominantly. The limb, axial muscles, or both can have lesser or equal involvement. Class 4 involves severe weakness of affected muscles. Ocular muscle weakness of any severity can be present. Class EVA involves limb, axial muscles, or both predominantly. Oropharyngeal muscles can be involved to a lesser degree. Class IVB involves oropharyngeal, respiratory muscles, or both predominantly. The limb, axial muscles, or both can have lesser or equal involvement. It also includes patients requiring feeding tubes without intubation. Class 5 involves intubation with or without mechanical ventilation, except when employed during routine postoperative management. Evaluation. The diagnosis of MG is mostly clinical. The laboratory investigations and procedures usually aid the clinician in confirming the clinical findings. Serologic tests. The anti-AChR flat test is very specific, and it confirms the diagnosis in patients with classical clinical findings. It is present in 4/5 of patients with generalized MG and only in half of the patients with pure ocular MG. The rest of the patients, about 5% to 10%, will demonstrate anti-MuSK antibodies. Only in a few sporadic cases, both anti-AChR and anti-MuSK antibodies are present in the same patient. The 3% to 50% of the remaining patients who are seronegative to either of these antibodies will demonstrate anti-LRP4 antibodies. Anti-striated muscle antibodies are present in 30% of MG patients. They are more useful as a serologic marker for thymoma, especially in younger patients, 2, 9, 12. Electrophysiologic tests. These are relevant in patients who are seronegative for antibody testing. Commonly employed tests for MG are the repetitive nerve stimulation, RNS, test in single-fiber electromyography, SFEMG. Both the tests assess for conduction delays in the NMJ. Routine nerve conduction studies are usually performed to determine the functioning of the nerves and muscles before undertaking these tests. RNS test. This is done by stimulating the nerve at 2 to 3 Hz. Repeated nerve stimulation depletes the ACH in the NMJ and produces a low excitatory postsynaptic potential, EPSP. A 10% or more decrease in the EPSP between the first and fifth stimulus is diagnostic of MG. SFEMG. This records action potential, AP, from individual muscle fibers, and thus allows to record the AP simultaneously from 2 muscle fibers innervated by a single motor neuron. The difference between the time of onset of these 2 action potentials is called the jitter. In MG, the jitter will increase because of the reduced NMJ transmission. This is the most sensitive among the diagnostic tests for MG. Edrophonium, tensilon, test. Edrophonium is a short-acting acetylcholinesterase inhibitor that increases the availability of ACH in the NMJ. This is particularly useful for ocular MG, where electrophysiologic testing cannot be performed. It is administered intravenously, and the patient is observed for improvement in the symptoms of ptosis or diplopia. It has a sensitivity of 71% to 95% for MG diagnosis. 4. Ice pack test. When edrophonium testing is contraindicated, an ice pack test can be performed. This test requires an ice pack placed over the eye for 2 to 5 minutes. Then, an assessment for any improvement in ptosis is done. This test cannot be used for the evaluation of extraocular muscles. Imaging. Chest computed tomography, CORT, or magnetic resonance imaging, MRI, should be performed in patients diagnosed with MG to assess for thymoma. In cases presenting with pure ocular MG, MRI of orbits in the brain needs to be performed to evaluate for any localized mass lesions. Other laboratory tests. Myasthenia gravis commonly coexists with other autoimmune disorders, and testing for antinuclear (ANA) antibodies, rheumatoid factor (RF), and baseline thyroid functions are recommended. Treatment, management. The mainstay of treatment in MG involves cholinesterase enzyme inhibitors and immunosuppressive agents. Symptoms that are resistant to primary treatment modalities are those requiring rapid resolution of symptoms. Myasthenic crisis, plasmapheresis or intravenous immunoglobulins can be used. Management strategies in MG are based on the following 4 principles. Symptomatic treatment. Acetylcholinesterase inhibitors increases the level of ACH at the NMJ by preventing its enzymatic degradation. Pyridostigmine bromide is preferred over neostigmine because of its longer duration of action. In those with bromide intolerance that leads to gastrointestinal effects, ambinonium chloride can be used. Patients with MuSK-MG respond poorly to these drugs and hence may require higher dosages. 13. Immunosuppressive treatment. These are indicated in patients who remain symptomatic even after pyridostigmine treatment. Glucocorticoids, prednisone, prednisolone, and methylprednisolone, and azathioprine are the first-line immunosuppressive agents used in the treatment of MG. Second-line agents include cyclosporin, methotrexate, mycophenolate, cyclophosphamide, and tacrolimus. These are used when the patient is unresponsive to treatment, has any contraindication to treatment, or intolerability to the use of first-line agents. Recently, various monoclonal antibodies, including rituximab and eculizumab, have been used to treat drug-resistant MG, but data from clinical trials about their efficacy is yet to be documented. 13. Intravenous immunoglobulins, IVIG, plasmapheresis. This is recommended during the perioperative period to stabilize a patient before a procedure. It is also the treatment of choice for the myasthenic crisis due to its rapid onset of action and used in cases that are resistant to immunosuppressive drugs. Thymectomy. This is indicated for the following. Any subtypes of MG with evidence of thymoma, non-thymomatous and AChR-MG, especially in patients aged 15 to 50 years, perform 1 to 2 years of disease onset. 14. Seronegative non-thymomatous MG. However, it is not recommended for the non-thymomatous MuSK-MG, since thymic pathology is rare, and non-thymomatous ocular MG without secondary generalization.